Microscopic polyangiitis is an autoimmune disease Look at this picture, shows that skin manifestation in leg, chest X-ray and CT scan to assess lung involvement. Look at this picture, shows that a detail going on. Introduction. Microscopic polyangiitis MPA is a rare autoimmune disease characterized by inflammation of small blood vessels, vasculitis. It primarily affects the kidneys, lung, and other organs, leading to significant morbidity and mortality if left untreated. MBA belongs to the group of anti-neutrophil cytoplasmic antibody ANC associated vasculitis along with granulomatosis with polyangiitis GPA and eosinophilic granulomatosis with polyangiitis EGPA. A definition: microscopic polyangiitis is a necrotizing vasculitis that affects small size blood vessels including capillaries, venules, arterioles. It is an ANC associated disease commonly linked to myeloperoxidase MPO ANCA antibodies. Unlike other form of vasculitis, MPA does not cause granuloma formation. Etymology. The term microscopic polyangiitis comes from Greek roots poly many, angio vessel, and itis inflammation, indicating widespread small vessel inflammation. The word microscopic refers to the disease small vessel involvement, distinguishing it from large vessel vasculitis. MPA does not have distinct subtypes, but it can manifest with varying organs involvement, including 1. Renal dominant MPA primarily affects the kidneys, causing rapidly progressive glomerulonephritis. 2. Pulmonary renal syndrome a combination of lung and kidney involvement. 3. Systemic MPA, widespread involvement of multiple organ systems. Causes. The exact cause of MPA is unknown, but it is believed to result from a abnormal immune system response that mistakenly attacks the small blood vessels. Possibly contributing factors include 1. Genetic predisposition. 2. Environmental triggers. Example, infections, toxins, or drugs. 3. Abnormal activation of the immune system. Risk factors. Several factors may increase the risk of developing MBA, including 1. Age. Commonly occurs in middle-aged and old adults. 2. Genetic susceptibility. 3. Exposure to certain environmental triggers, example silica, pesticides, infections. 4. Autoimmune conditions, example lupus, rheumatoid arthritis. Complications. If left untreated, MPA can lead to severe complications such as 1. Kidney failure due to glomerulonephritis. 2. Pulmonary hemorrhage, potentially life-threatening bleeding in the lungs. 3. Peripheral neuropathy, nerve damage causing weakness or numbness. 4. Skin ulcer or necrosis due to vessel inflammation. 5. Cardiovascular involvement, increased risk of heart disease. Pathophysiology. Microscopic polyangiitis is a small vessel vasculitis characterized by inflammation and necrosis of capillaries, venules, and arterioles. It is associated with myeloperoxidase, anti-neutrophil, cytoplasmic antibodies. Step by step pathophysiology of microscopic polyangiitis. 1. Genetic and environmental triggers. Genetic susceptibility and environmental factors, example infections, drugs, or toxins, may trigger an autoimmune response. This leads to the production of autoantibodies against myeloperoxides, MPO, a neutrophil enzyme. 2. Development of MPO ANC. The immune system mistakenly produces MPO ANC which targets myeloperoxides in neutrophils. ANC antibodies are thought to be produced due to molecular mimicry or inappropriate immune activation. 3. Neutrophil priming. Inflammatory cytokines prime neutrophils, making them more responsive. This priming leads to increased MPO expression on the neutrophil surface. 4. ANC binding and neutrophil activation. MPO ANC binds to primed neutrophils via Fc receptors. This activates neutrophils, triggering degranulation. NET oasis, neutrophil extracellular trap formation, which releases more MPO and autoantigens. 5. Endothelial damage and small vessel inflammation. Activated neutrophil adheres to the endothelium and cause direct endothelial injury via ROS and proteolytic enzymes. Release of pro-inflammatory cytokines leads to further immune activation. Fibrinoid necrosis of vessel walls, a hallmark of small vessel vasculitis. 6. Immune cell infiltration and tissue damage. The damaged endothelium attracts monocytes, macrophages, and T cells, worsening inflammation. This results in leukocytoclastic vasculitis, thrombosis, and ischemia, leading to organ dysfunction. 7. Multi-organ involvement. 1. Kidney. Passive immune glomerulonephritis, rapidly progressive GN with crescent formation. 2. Lung. Pulmonary capillaritis, alveolar hemorrhage, presenting as hemoptysis. 3. Skin. Non-blanching palpable purpura from vessel damage. 4. Nervous system. Mononeuritis multiplex due to ischemic injury to peripheral nerves. MPA is an autoimmune disease where MPO ANC activates neutrophils, leads to endothelial damage, necrotizing vasculitis, and multi-organ involvement. These key features are immune glomerulonephritis and pulmonary hemorrhage, distinguishing it from other vasculitis. Signs and symptoms. Symptoms vary depending on the organs affected but commonly include 1. General symptoms fever, weight loss, fatigue, night sweating. 2. Kidney involvement, hematuria, proteinuria, renal failure. 3. Lung involvement, cough, hemoptysis, shortness of breath. 4. Skin manifestations, purpura, ulcers, nodules. 5. Neurological symptoms, peripheral neuropathy, muscle weakness. Diagnosis. Diagnosis involves a combination of clinical evaluation, laboratory tests, and imaging studies. 1. Blood test. Elevated inflammatory markers, CRP, ESR, ANCA. Positivity, MBO, ANCA. 2. Urine analysis, proteinuria, hematuria, and blood cell cost. 3. Imaging, chest X-ray or CT scan to assess lung involvement. 4. Tissue biopsy, kidney or skin biopsy to confirm vasculitis. Nursing diagnosis. 1. Impaired gas exchange related to pulmonary hemorrhages. 2. Ineffective renal perfusion related to glomerulonephritis. 3. Risk for infection related to immunosuppressive therapy. 4. Chronic pain related to systemic inflammation and neuropathy. 5. Fatigue related to chronic illness and medication side effects. Disease management. First, medical management. 1. Immunosuppressive therapy, corticosteroids to reduce inflammation, cytotoxic agents to suppress the immune response. 2. Plasma pheresis used in severe cases to remove ANC antibodies. 3. Supportive therapy, antihypertensives, anticoagulants, dialysis for renal failure. Nursing management. 1. Monitor vital signs and respiratory status. 2. Assess for signs of infection due to immunosuppressive therapy. 3. Educate patients on medication adherence, and side effects. 4. Encourage a balanced diet and hydration. 5. Provide emotional support and coping strategies. Treatment options. 1. Induction therapy. High dose corticosteroids plus cyclophosphamide. 2. Maintenance therapy. Azathioprine, methotrexate to prevent relapse. 3. Supportive care, dialysis for kidney failure, oxygen therapy for lung disease. Psychosocial medicine. 1. Counseling and psychological support to help cope with chronic illness. 2. Support groups encouraging participation in vasculitis support communities. 3. Stress management techniques, meditation, yoga, relaxation exercises. 4. Education programs enhancing knowledge about disease management. 5. Family involvement, encouraging family support and understanding. Prevention. This is no known way to prevent MPA, but early detection and management can reduce complications. Key preventive strategies includes 1. Regular medical checkup for at-risk individuals. 2. Avoiding known environmental triggers, toxins, smoking. 3. Maintaining a healthy immune system through proper nutrition and exercise. In conclusion, microscopic polyangioitis is a life-threatening autoimmune vasculitis that primarily affects the kidneys and lungs. Early diagnosis and aggressive treatment with immunosuppressive therapy can significantly improve outcomes. Ongoing research and advancements in treatment options continue to improve the prognosis for patients with MPA. Thank you. Have a nice day.